my friend Rainer, who has been so active, and it was a great opportunity to cooperate with him on various aspects, especially the Global Psychiatry Archives. And then also this Global Psychiatric Congress, which has been a great opportunity for all of us to work together. And the topic I have chosen for is challenges faced by low and middle income countries, access to mental health care. And this is a very important topic. We often speak about access to care and how access is not available to most people. We also speak that any care should be accessible, and we also say that it should be affordable and it should be available. So at least in many parts of India, the accessibility, especially in rural parts, is very limited, and it's also very true about the other low and middle income countries. So that's why I have chosen this topic. By your introduction, I would like to say that access to care in low and middle income countries is a complex and multidimensional concept. Equitable access to care is a goal for all countries, and challenges include high burden of health needs and chronically under-resourced health systems. This I would like to particularly emphasize, that mental health has always received a stepmotherly treatment in most of the low and middle income countries. And it is never a priority for the political classes because they don't form a vote bank. The most vulnerable face the greatest barriers to access: people living in socioeconomic deprivation, ethnic minority groups, and women, which is well known. And because women, of course, they are in most low and middle income countries, they are destined to look after the family, and their own health or mental health becomes the lowest priority. Ethnic minorities face discrimination in most parts of the world, and so these are some of the difficulties, challenges in access to care. Access to mental health care defined, measured in very different ways. Research on access to healthcare has been widely conducted for several decades across countries, methodological approaches, and disciplines. Numerous conceptualizations and theoretical models of the impact of access to healthcare on health have been proposed. Key challenges of research on access to healthcare is how closely related this topic is to its social context. This is just, I have taken various definitions of access to care. Quote, the ability to reach, obtain, or afford entrance to services. This is one way, or a focus on the supplier side, that is, providers of healthcare was developed by defining access to the availability of services or opportunity to use services. And third would be access as should be conceptualized in terms of utilization of services. And a multi-dimensional concept based on the interaction between healthcare systems and individuals, in which the dimensions of availability, affordability, and acceptability interact to affect people's empowerment. So we feel that this is a multi-dimensional concept, access itself. In fact, all of these definitions put together will give us the real concept of the access to care. Now a bit about the burden of mental illness in low and middle income countries. More than 80% of the people who have mental disorders are residing in low and middle income countries, and mental illness and substance abuse disorders account for about 9% and 17% of the total burden of disease in low and middle income countries, respectively. By 2030, depression alone is likely to be the third leading cause of disease burden in low income countries, and the second highest cause of disease burden in middle income countries. Social factors such as poverty, urbanization, internal migration, and lifestyle changes are moderators of the high burden of mental illness in many low and middle income countries. Depressive disorders, schizophrenia, bipolar disorder, and alcoholism disorders are among the top 10 causes of disability due to health-related conditions in low and middle income countries. We can say that among the top 10, at least 4 of them are mental health problems, depressive disorder, schizophrenia, bipolar, and alcohol. This only shows how much priority we should be giving to mental health disorders. They represent about 19% of all disability-related health conditions, about 1/5 of that. A significant proportion of the population being the younger age range increase the incidence of severe psychiatric disorders such as schizophrenia. When we speak about burden of illness in low-income countries, most people speak about malignancies, cancers, or coronary artery disease. But mental health problems often occur in very young age, and as you know, it becomes a major health problem. 21.5%. 21.5% of the population in Pakistan are in the range of 15 to 24 years. That is very young age group. Similarly, 47% of the Saudi nationals and 41% of the total population of the Kingdom of Saudi Arabia 21 24 years of age. So I'm just taking the nearby Asian countries before coming to India. India is a prototype of the low and middle countries because population is more than 1.4. It's now 1.45 billion, and India has become the most populous country in the world. People under the age of 25 years constitute about 47% of the country's population, and population under 25 years of age includes 47% male and 46% female. One of the interesting aspects is that the death rate in India has witnessed a significant decline over the last 4 decades, from 15% in 71 to just 6% in 2018. Young people, rich divide. Young people, rich dividend. Access to their mental health care is the best investment. So this is something we try to tell the policymakers. We have many young people, and the young people in India are far outnumbering the older people, and invest in their mental health. It is going to make a rich dividends. And some of the key legislations, key challenges in these countries are legislation and policy, and finance and resources. Of course, we know that very trivial amount is spent for mental health. Organization and planning, there is little organization and little planning. Availability of appropriately adapted evidence-based interventions and training. So these are the key challenges which I can foresee. In taking up legislation, many low and middle income countries lack mental health policies and laws to direct their mental health programs and services. Family and user associations are present in LAMICs, but do not have a strong influence in the development of policy and procedures. Serious oversight, considering that the majority of people with mental illness and low and middle countries are supported by the large family unit. So here is one point I would like to specially mention, that especially in the Asian region, the family has a major role in the treatment of mental health problems. In my unit, I have 40 beds, and almost invariably everybody is accompanied by a family member. This is almost impossible. I'm sure when I was a WPA General Secretary General, I was working in the University Hospital, Geneva, for 6 years, and I have seen that this hardly ever takes place which most of you know very well. So this is one aspect which I would like to highlight. The family is a big source of strength in the low and middle income countries, and we must make use of them. WHO describes the necessary step to follow, but does not detail how this can be contextually relevant to a particular culture. So this is, if suppose we blindly follow a WHO manual, we will definitely reach a blind alley because we do not know how it applies to a particular culture. So these are, WHO has done a good thing is for people like many of us to develop culturally relevant, contextually relevant systems, how we can implement them. So finance and resources, many low-income countries, including 15 of the 19 African countries, allocate less than 1% of their health budgets to addressing mental illness. So this is a very serious situation. Primary source of mental health financing in descending order are out-of-pocket expenditure by the patient or family. This is a huge burden on the families. In fact, they form the number one resource for mental health expenditure. Taxes, social insurance, and private insurance. India is a fast-growing economy, now the fifth largest global economy, but it spends less than 2%, spends 2% of the country's GDP on healthcare in 2022. This to reach 2.5% GDP by financial year 2025 and 1% of the health budget. It's very trivial. So it's health budget. We are trying our level best to convince the administrators and the policymakers. And our efforts have, of course, I'm sure the efforts are, I won't say it's a failure. It has partially succeeded in increasing the finance allocation to a large extent, but not enough. We have miles to go before we sleep and miles to go before we sleep. And then organization planning, key organization barriers or difficulty in access. How to make accessible. The combating public health priorities. Now, public health priority, for example, when the COVID came, all other priorities were lost. For example, mental health became very low priority, and even vaccination. Low. So there is always a combating public health priority. Low investment in mental health services, a paucity of specialist human resources, and resistance to decentralization. For a country, huge country like India with 1.4 billion population has just 7,000 psychiatrists. Making one psychiatrist who take care of 200,000 population, which is an impossible task. The number of psychologists, social workers, psychiatric nurses are equally less. This is very true, not only about India. If you take other South Asian countries, it is even lesser. So this is something which is we have to find a solution. We are there in the resistance to decentralization. In India, mental health services are integrated into primary health services with support and supervision from mental health teams at the district level. However, not all districts are covered under this program, and many primary health care physicians have not received any up-to-date training in mental health. This demonstrates a lack of organizational planning in this important area. Of course, this is some of these things we have to look into. Availability of appropriately adapted evidence-based interventions and training. Psychotherapeutic interventions are not included in mainstream treatments in many LAMIC countries. That is a very sad state of affairs. This can be attributed to two main reasons: lack of resources and inadequate training. Despite the strong evidence for its effectiveness, cognitive behavior therapy and many other psychotherapeutics and social interventions remain underutilized in clinical settings internationally due to the limited availability of comprehensive training programs and qualified CBT mental health professionals. In addition, as currently delivered, CBT has been criticized as being West-centric and not in tune with different cultural beliefs. Of course, we have to look into this. We have to make CBT and a tool which is appropriately culturally relevant, and also how relevant it is to the Eastern philosophies. For example, we speak about in India, but the Guru-Chela relationship, which is very different from the Western context, where the therapist is at equal level, almost at equal level with the client. But in India, the Guru-Chela relationship, the therapist is seen as a guru, is a teacher who knows everything, and the disciple looks upon him to take decisions and to guide him. Very true in psychotherapy as well, which is modeled on this basis. So we cannot just abandon our patient saying that you decide for yourself. So these are some of the contextually different characters we find in many of the low and middle countries. Now, key challenges. Psychiatrists continue to advocate for the introduction of mental health care in primary care without acknowledging the complex realities of primary care in low and middle countries. Nevertheless, the addition of mental health programs requires robust primary health systems. Primary care in lower countries at present systematically underfunded and impoverished, is unable to successfully integrate mental health care. Case Jacob has very nicely brought this out. The primary care, integrating mental health in the primary care is a very wonderful idea. It's an excellent idea. But the mental health care is overburdened. They are not able to look after even their own priorities like vaccination or child and maternal health programs. So introducing mental health becomes a difficulty. So it's not that the idea is good, but we have to work to strengthen the primary care first and then integrate. And also to think of other strategies. I would just like to briefly speak about the National Mental Health Survey in India because it's a survey which has been hailed as one of the excellent survey, which was done under the leadership of the National Institute of Mental Health and Neuroscience in Bangalore. I would just highlight some of the key findings. One is the mental disorders contribute to a substantial disease burden. So we need this data to tell the politicians. Excluding tobacco use disorders, mental morbidity of individuals above age of 18 years was 11%. The lifetime prevalence in the survey population was about 14%. Prevalence of mental morbidity is high in Indian urban metros. The prevalence of schizophrenia and other psychosis. I have given the percentages in the brackets. The mood disorders and neurotic stress-related disorders, they're quite high at about 7%. Was nearly two to three times more in urban metros. So urban metros have a key role. One of the key areas where mental health strategies need to be worked into. So this is a graphic representation of the rural-urban differentials in prevalence of the mental disorders. You can see that the maroon bar represents the urban metros, which is quite high for the in total as well as psychotic disorders, MDD, neuroses. So you can see that it's quite. Then others are common mental disorders, including depression, anxiety disorders, and substance use disorders are huge burden affecting 10% of the population. 1 out of 20 people in India suffer from depression. And there is high prevalence of psychoactive substance use. Substance use disorders, including alcohol use disorders, moderate to severe use of tobacco, and the mild one is excluded, and use of other drugs, illicit and prescription drugs, was present around 22% of the population above 18 years in all the 12 surveyed states. It's a huge 1/4 of the population above 18 years using substances. It's a very serious challenge. So we have to look into this. And then high suicidal risk is an increasing concern in India. Nearly 1% of the population reported high suicidal risk, total population. And the prevalence of high suicidal risk was more in the 40 to 49 age group, about 1.2%, among females, and in those residing in urban metros, which is 1.7%. The overall prevalence of mental morbidity was higher among males, 14%, than among females. So more of the Indian male suffer from mental morbidity, probably because of the heavy burden of the family. Family burden is there, and also because of the substance use disorders, which are much more prevalent in the males than the females. Female alcoholism is much less in India, maybe less than about 2%, but it is much higher in the males. And this is again prevalent of mental morbidity in different age groups. You can see that the 40 to 49% age group and the 50 to 59%. Interestingly, people above 16% also, 60 and above, also contribute 15% have a mental health problem. And the largest survey of mental morbidity in India, 150 million individuals suffer from mental morbidity in India. This information should be used for planning, delivery, and evaluating mental health programs in the country. This data helps to strengthen and implement mental health policies and programs. This builds a strong case for increased mental health care, increased investment in mental health, and to make mental health priority. Of course, the Indian Psychiatric Society, as well as various other organizations, the lead institutions like National Institute of Mental Health and Neurosciences, PGI in Chandigarh, and others are using this data to advocate for mental health advocacy. We need time because mental health is, of course, as usual, mental health is not a subject of any relevance or in the forefront of our thought process for the policymakers. Now, coming to the end of my presentation, the way forward, suggested approaches. I would suggest that we should develop guidance on standardized reporting of community components for mental health services. Study approaches to increase service, user, and family involvement in developing and implementing community mental health services. As I was saying in the beginning, family involvement becomes very crucial, and their opinions and their values are very, very important. Their suggestions need to be taken. It's true of all countries. Develop tools to study and promote competencies in community mental health care, and use these for research and quality improvement. So competencies are available in the community that should be used. For example, competency among the non-government organizations, the family members, even among users. And this is used for quality improvement. Use technology to expand the scope and improve the quality of community and mental health care services. Telemedicine is one of them. Integrate and evaluate tools for service providers and service users to enhance reach and effectiveness of community components. I will mention about these, some of these experiments in India later. Better integrate community platforms into other systems of care. So just let us not put a community platform as a standalone concept. It should be integrated into primary care. It should be integrated into the private mental health services, integrated into the non-governmental organization, to rehabilitation centers. And these are some of the promising initiatives. One of them is, which we have published, effectiveness of a new low-cost psychosocial rehabilitation model to reduce burden of disease among persons with severe mental illness, an interventional follow-up study, which was led by me and my team. And here we can see that we have been able to provide a community-based service, and we had the low-cost psychosocial rehabilitation model was found to be effective. This could serve as a model not only for other similar centers in India, but also for other low and middle income countries. We used art, we used theater, we used music, and we used other rehabilitation models to provide better quality of care for our people. This is another, the NIMHANS, effectiveness of the NIMHANS eco-blended tele-mentoring, a model on integrated mental health and addiction for counselors in rural and diverse districts of Chhattisgarh, India. So from NIMHANS, they have managed this care for a very rural area in India. This is another, by distance training for delivery of psychiatric service in primary care. And this is then designing and implementing an innovative digitally driven primary care psychiatry programs in India. Some of the interventions which have been published. And then promising schizophrenia and research foundation. And this is one. Maria Sadanam in Para, this is one of the centers under where I am the chief mental health advisor. I mean, this center, for example, is there are 450 people who have recovered from mental health or partially recovered are housed here undergoing rehabilitation. They are trained for various livelihood, and once they are better, they are sent back to the community. This is an NGO run, and this is entirely funded by the contributions from the public with very little government support. So you can see that. Just want to bring to the attention the valuable services given by the non-state actors in various parts of India. And in conclusion, I would say that, quote, of all the models by which patients may be induced to restrain themselves, regular employment is perhaps the most generally efficacious. We had to work with companies, working with various industries. In India, what we have 2% of corporate social responsibility, CSR funding, So the government has mandated that 2% of their profit should be earmarked for corporate social responsibility. Most of these funds do not come to mental health. They go for cancer care. They also go for tertiary or quaternary care in cardiac services, bringing in cardiac catheterization. But bringing mental health is our agenda, and we hope to succeed in the years to come, and persuading at least some of them to think of mental health as a priority area. It's a very difficult task because one of you are not in the radar of politicians, because we come in the radar themselves, come in to seek our help, and once they seek our help, they always do it in because of the stigma and discrimination. They always do it in private, and hardly anyone would like to publicize their publicize themselves as users, one of the benefits. But slowly, for example, Kerala is a state where we have been able to overcome to a large extent. Kerala is where I work, is the southernmost state in the country, where literacy is quite high, it's 96%. And this is one state we have we have about 34 million people here, and we have 1,000 psychiatrists, which is far higher than the national average. So this is one, and psychiatry has gained acceptability. Another thing which has happened here is what we call one revolutionary change here is what is known as a general hospital psychiatry. Psychiatry units have sprung up in all the districts and small towns, maybe 10 beds, maybe 20 beds, but they have gained acceptability. But again, we have a lot of stigma. The Mental Health Care Act, which in India, which has been modeled it has actually a cut and paste model by some of the policymakers, where it makes sometimes difficult. Practice becomes difficult. Recently, I was some of the unit, a psychiatry unit functioning in a medical college. The professor called me and said, now they are asking us to take registration under the Mental Health Care Act of India. Why are you stigmatizing psychiatry? Why no other branches in medicine need such a certificate? These are some of the important questions in law and medicine countries, which we had to sit together and find out reasons. And these are some of the references. Thank you very much for your patient hearing. Thank you. I am coming to the end of my presentation. Thank you.
Right.
I can stop sharing, I think. Yes, is it possible, or?
I think you can stop sharing. Yeah,
Thank you so much, Professor Roy Abraham, sir. I have just a single query to confirm. The World Mental Health Survey that was conducted in early part of this century, they found a mental health treatment gap of somewhere around 90% patients were having psychiatric illness, but they are not able to get the mental health care. So treatment gap was around 90%. When it comes to National Mental Health Survey of 2015-16, the mental health treatment gap was found to be somewhere close to 85%. I'm expecting that during this COVID times, the mental health system was completely collapsed. People were not able to have access to mental health care. So the gap must have increased to multifold. But recently, over past 2 years, at least the government has taken an initiative to start providing the online services, particularly starting the tele-managed services, which is being implemented in many parts of the country. And the district mental health program has also been implemented in many of the districts of several states. So now the National Mental Health Survey is again going to be held in 2023 and 2024. It has been initiated the phase 2 of the survey. So what do you expect that the treatment gap will be changing? What is your perspective about this?
I fully agree with you that there's a huge mental health gap, and our aim is to reduce this gap. And I also agree that COVID, we really faced a very tough situation where patients in India and other low and middle income countries, they simply went without any treatment because they were not at all considered as a priority person to make costly investments. In India, of course, these are minus and tele-psychiatry schemes. Various state governments in Kerala also they have implemented what we call suicide prevention helplines. But that they're all good. But I think that is not enough. In psychiatry, at least I believe, at least our experience shows that a person-to-person interaction facilitates empathy. And what we have observed in through telepsychiatry, our experience has been when acute problems are there, they seek our help. So we talk to the at a distance. We talk to the primary care physicians. We make a diagnosis of acute, maybe schizophrenia or mania, and then the treatment is provided, but they hardly come for follow-up. Once after 3 months, follow-up is almost nearly, it comes down heavy, drastically down. But as in person-to-person interactions, we have followed up in our hospital. I have seen, I was part of the National Mental Health Program in India. I was in charge of the Idukki district in Kerala when I was a professor in Kottayam Medical College, which is a government college. At that time, the WHO sent one of its advisors. And he looked up at the files and he told me that if you have 30 to 40% of persons coming for review, I would rate your system as excellent. Of course, we are at least about 50% at that time. In our institute, we have found that the follow-up rates are about 70%. But when it comes to telepsychiatry, it comes down less than 20%. And so that is a difference. I talk to the politicians, they don't want to listen to you because they want to say that by telepsychiatry, we are covering the entire population, which is, of course, they are covering, but they are not following up. We know that mental health disorders, schizophrenia, bipolar, they all need long-term treatment. They need prophylactic care. We have to advise patients, you have to take lithium and you have to take periodic lithium estimations. You have to do, we have to take all these things. You should not, when there is a dehydration, you should have to stop medication. All these things are, and all these things become very difficult. But they are excellent initiative. And but I'm sure the initiatives in India, I applaud them. We hope to reduce the mental health gap to at least manageable limits, at least 75%, maybe by 2030. Let's hope so. Thank you.
Yeah, can I ask one question? So maybe, what is it what poor countries and what rich countries could learn from your approaches? And the second thing I'm quite interesting on the news, that caste is still a problem in India. So what does it do? So is caste a problem or is it a helper or what can you do? So these are the two quick questions.
Yeah, first is what the rich countries and the lower income, low and middle income countries can learn from each other. So rich countries should also always learn when you prescribe, for example, most of the guidelines, most of the textbooks, they all emanate in the Western authors. The guidance come from there. They all discount the involvement of the families in the eastern or the low and middle countries. So we should always keep the interest of the family also, because family in most of the Western developed countries, they are user driven, where the patient decides what is best for them. But in countries like India, person is a member of the family. If my brother is ill, the entire family is concerned about. They are genuinely concerned. That has been the culture of the society. It's not something which we are asking people, no, brother, you come, you take care. No, they are there already because they are part of their family. They have grown up together. And this resource has to be utilized. And coming to your second question, which is very interesting about caste. This is, this is very surprising. Caste system is very much there. But, scientists are, unfortunately, they are probably, I don't know why it is happening. They don't study this aspect. I don't know, they are politicians, they are probably afraid of politicians. I have hardly come across any of the diseases in a high caste, low caste, or the intermediate caste people. This is one area of research which we should keep in mind. Thank you.
Thanks a lot. Maybe you can ask if there's any other questions. I don't know. Someone.
Any other questions, please? Or any other one want to add something to the presentation?
One thing I just add is, since Rainer has mentioned about caste, in India we have two types of people who are very underprivileged. One who are known as the scheduled tribes, and the other is known as the scheduled castes. The scheduled tribes are, you can say, people who are indigenous people. Mostly they are living in the forests. And even now they have very little access to the civilization, except in some of the states like Kerala, where they are, they still live remotely, but people are able to connect with them. So there the treatment has not reached them. Access to care becomes maybe 1%, 2%. And in this other underprivileged caste is scheduled tribes. In many, at least in some places, of course, not Kerala is not one of them. I find that there is difficulty because sometimes it is although forbidden by law, people sometimes practice untouchability, which means it's very inhuman to keep one of your persons as an untouchable. So these are some of the things which may be there, which they are not publicly acknowledged, but we have to keep all those things on our mind. And it's in an egalitarian society. Yes.
Okay.
Yes.
They're visible?
They are visible. Yes.
All right. Well, thank you very much for inviting me. This is the second occasion in which it would be very interesting at some stage to learn more about the people who are with us in these meetings. I hope that you will give us an opportunity to learn who was listening in and in what way we can be in touch with them, since they are interested in what we have to say. Now, I've been suggested that I should speak about the community care in the year 2023. And I think that we have to remember that in the middle of the past century, 20th century, there was a number of important statements that have been made to create a strategy, postulates of mental health care, how it should be done. And one of the things which was quite clear is what the mental hospitals, which in the past have served sometimes a good role and very often been neglected and therefore fallen into a state of disarray where the patients had a very bad time. But that these mental hospitals should be closed. There should be people who have mental illness should be treated in psychiatric ward.